Okay, and with that, I'm going to turn it over to Ellen Bosang. She's Lighthouse's President and Chief Revenue Officer, and she'll be introducing our other guests today.
Thanks, Alex, and good morning or afternoon, wherever you happen to be. And thank you for joining us today, everybody. As Alex mentioned, I'm Ellen Bosang. I'm the President of Lighthouse Laboratories and Chief Revenue Officer. I've been with Lighthouse for about 5 months. Why I'm sitting as part of the panel is prior to Lighthouse, I also was the Chief Commercial Officer at BioReference Healthcare, which was a national reference lab at one time and now predominantly serves the New York and New Jersey market. And I've been in the healthcare industry for over 25 years. At Lighthouse, we pride ourselves in delivering webinars that help provide information on the topics that clients inquire about or have been hot topics, if you will, in the lab industry. The opioid risk assessment topic has been coming up a lot lately and something that Lighthouse has been engaged in and asked about frequently, given the physician referral labs that we have as clients. Given the physician and referral lab, that we have as clients. So we brought on 2 guests who will be a part of the panel today. The first is Dr. Michael Sprintz from Cellarian. Cellarian creates automated patient-specific medical necessity documentation and prior authorization letters for clinical reference and physician-owned labs. Cellarian's documentation will help optimize revenue and ensure compliance, which is critically important, and reduces recoupments, again, critically important, allowing your labs to keep their revenue while enabling providers to focus on patients. So I've been working with Dr. Sprintz for a while. He's the founder of Cellarian. He's a national expert on the intersection of chronic pain and addiction with a deep domain expertise in drug testing and digital health automation. He received training at Johns Hopkins and MD Anderson Cancer Center and is triple board certified in pain medicine, addiction medicine, and anesthesiology. Dr. Sprintz was a member of the 2017 ASAM Drug Testing Expert Panel, which published the most comprehensive guidance on clinical drug testing to date, and in 2013 started clinical practice treating chronic pain and substance abuse disorder patients, which included an in-house toxicology lab. The second guest we have on our panel today is Jane Pinewood from McDonald Hopkins. For over 50 years, McDonald Hopkins has provided legal service to individuals and entities in the healthcare industry. McDonald Hopkins' diverse national practice enables the firm to provide a unique perspective on the issues its clients face in the rapidly changing healthcare environment. The firm utilizes its knowledge of the business, financial, and operational components of the healthcare industry to deliver value beyond traditional legal services. I've had the pleasure of working with Jane when she was Chief Legal Counsel at BioReference Healthcare, but Jane has a 38-year experience of representing clinical, molecular, and anatomic laboratories, pathology providers, hospitals, health systems, physicians, and other healthcare providers in corporate, regulatory, reimbursement, contractual, and other matters. So as we start to think about risk assessment in the opioid area, when I think back to my time at BioReference and in the reference lab world, I think one of the biggest concerns from a reference laboratory we always had was reimbursements. So it can have a downstream effect on the financials at the laboratory, but certainly a downstream effect on healthcare. So labs, when they are forced with denials or when they're looking at reimbursement and not getting reimbursed for the testing that they're performing, they have to make some difficult decisions. And as a reference laboratory, we often had to make difficult decisions around, do we offer the testing at all? So do we have to decrease our menu, which then puts our physicians in a tough spot because they have to think about where they can get that testing and also how often patients can get that testing, as well as patients because of healthcare insurance needs and going to where their physician is ordering the testing. Additionally, for our folks who are physician-owned laboratories, there's concern with regard to denials and reimbursement. As we're seeing a decrease in reimbursement, we also are seeing an increase in the failure of audits for overutilization of testing. So it does pose a big concern, obviously, whether you're at a reference laboratory or whether you have a physician-owned laboratory in your practice. Jane, I'm going to turn it over to you to discuss some risk perspective from the legal angle.
Oh, thank you very much, Ellen. From a legal perspective, there are at least two major areas of risk that we look at. The first one, and I will say in the big picture, the really important one, and that is the legal risk that accompanies failure to provide adequate patient care to patients. I mean, what we're talking about here with opioid testing is something that is critically important given the opioid crisis that continues in this country. And these are patients who could be at very, very high risk of overdosing with complex medical issues. So it is very important that we remember in any type of risk assessment that we're not just worried about what can we do to make sure testing is paid, but also what are the consequences of a failure to test or a failure to adequately test, because that can put patients at risk. And there is other risk, not payer risk, but rather malpractice risk that is associated with inadequately assessing patients and following up with patients. So again, a very significant concern. On the other hand, though, and often at odds with the patient care issues are the payer issues that Ellen mentioned. The area of testing, or one of the most frequently targeted areas of testing for payer audits and recoupments, is toxicology testing. And unfortunately, many payers view this as an area ripe for abuse. I don't think it's a surprise to anyone that there have been laboratories in the past that have taken advantage of the system and have been known as, bad labs, in quotes, that were testing everyone for everything all the time. And unfortunately, they have cast a lot of the opioid testing in a negative light for payers. What's important to remember is for whether you're a POL, whether you're a large laboratory or medium-sized lab, your toxicology testing generally does run a higher risk of being audited by a third-party payer. And what is it that third-party payers want to see? And that's really the basis of this presentation today and what Dr. Sprintz will be speaking about. They want to see documentation to establish medical necessity. What's important to recognize here, and I know it can be very, very frustrating for healthcare providers, medical necessity is not what those two words would mean to most of us. Medical necessity is what a payer determines meets its coverage guidelines. So even though a healthcare provider who's treating a patient says this is medically necessary for my diagnosis and treatment of the patient, that doesn't mean that the payer considers it medically necessary. In an audit, there are 4 things that payers want to see almost universally. And this is part of the burden upon a laboratory to ensure that these 4 things exist. One of them is documentation in the patient record, or that is drawn from the patient record, to explain why the healthcare provider needs this test in order to diagnose and or treat the patient. So it's basically establishing the reason for the testing that is in the medical record or drawn from the medical record. Second is a signed order for a test. And again, most most payers want to see that the healthcare provider has actually signed the order. Third would be a copy of a test result showing the test was actually performed. But the fourth element, and this is one that post-COVID, post the pandemic, payers are increasingly requiring, and that is documentation in the medical record or drawn from the medical record, indicating that the ordering provider reviewed the test results and incorporated them into a diagnosis or plan of treatment for the patient, somehow demonstrating that those tests were actually used. Because if there's nothing in the medical record to document use of the testing or review of the test results, the payer likely will take the position, well, obviously it wasn't medically necessary if it wasn't documented that it was used. And again, the big issue here, the big thing to remember is from a payer standpoint, if it's not documented, it was never done. And with that, I will turn it over to Dr. Sprintz, who has all of the details on this.
Thanks very much, Jane, and thanks, Ellen. It's everything that both Ellen and Jane said really covers at a large level the problem that we have here. And I know that healthcare providers, and having run a clinical practice for years with the toxicology lab, and even in my role with Cellarian in automating medical necessity documentation, the reality is, and as Jane said, if it's not documented, it didn't happen. And more importantly, better documentation, and this is something that Jane had said, better documentation on the front end equals higher likelihood of reimbursement and revenue retention on the back end. And from a clinical perspective, you've got the issue of, well, we don't have enough time, everyone's moving quickly, and I ordered the test, so therefore it must be medically necessary. And that's a big challenge that we have now, in that you have to put more in. And now we're going to talk about the opioid risk assessment. And, when we talk about prescribing opioids, everyone has been really focused on opioid use disorder, which is obviously very important. But as a clinical provider, it's not just about OUD. It's about all opioid related harms. And that's really important. And so when we think about things, ultimately, what are the goals for both labs and providers who own labs as well, is, well, we want to give the best care and we want to get paid for the services that we're doing. And in order to do that, we have to document well enough to support why we are doing what we're doing, why those services were provided. And that's really challenging in today's environment. And so one of the things that we've noticed recently is the Medicare payers have now started to tie frequency of testing with risk, right? With opioid risk. And unfortunately, one of the ways that that's really been pushed out really hard are validated opioid risk screening tools. And those are really just literally screening tools, such as the ORT or the SOAP-R. There's a couple other ones. And in the past, everyone has thought, oh, well, that's all I need to do. One of the biggest problems with these validated risk scores, and I want to be really clear, as an addiction and chronic pain specialist, I need to tell you, these risk scores are not addiction diagnosis genies, right? And there's been this over-reliance. Well, their ORT was low, so I don't have anything to worry about. And the reality is you do, both from a clinical perspective as well as from a reimbursement and compliance perspective. So these validated risk scoring questionnaires, they're filled out by a patient. And they're most often filled out by a patient going in with a chronic pain problem. And so as a patient going into a pain practice, they want to look as good as they possibly can. And I think that these tools are great for identifying someone who doesn't know they have a problem, right? But for the vast majority of people who may have a problem or overusing stuff, they want to look as good as they can in front of their provider. So they're going to minimize the risks. What that does is that results in an unusually skewed amount of low risk patients. But again, as providers, when we are looking to evaluate risk of opioid related harms, it's not just opioid use disorder or a substance use disorder. The best example I can think of is you've got a patient, an 83-year-old lady who's taking gabapentin and hydrocodone, and from an ORT, from an opioid use disorder perspective, they are low risk. But here's a medically fragile patient who is elderly, who also has, comorbid lung problems, and is on 2 central nervous system depressants, an opioid and gabapentin. And in fact, in 2019, the FDA actually put out a warning about the use of gabapentinoids and other CNS depressants in combination because of the increased risk of respiratory depression and death. And so the thing when we've been really pigeonholed into thinking about opioid risk only in terms of addiction-related issues. But we have to expand our perspective about opioid risk to really encompass all opioid-related harms, which is accidental overdose, respiratory depression, falls, We've got patients with obstructive sleep apnea, with COPD, who may have some cognitive dysfunction, right? Elderly patients that may have, early onset dementia. They forgot that they took their medications. And so as you start to think about this, these patients who may be at very low risk for an opioid use disorder, they're at an extremely high risk for an opioid-related harm. And that's really key. So as we're talking about how do I assess risk, you want to broaden your perspective. And again, when I think about patient care, I always think about what's best for the patient and what will I say on the stand. And if I have a patient like that and I don't think about or didn't document that I understand the overall risk for this patient, and in this patient, the risks outweigh the benefits, the benefits outweigh the risk, it's really hard to defend if you're sitting up there and you're like, well, this 83-year-old lady overdosed on the oxycodone that we were prescribing for them with the gabapentin. You're like, well, their opioid score was low. Well, it's not just about addiction. And so that's really key. And what we're going to talk about and show you later on is a simple worksheet that we've put together to make it simple and easy for providers to document overall opioid risk in a simple, easy way that fits into the workflow. So it doesn't burden the provider, but it creates the level of documentation that you as either a clinical reference lab or a physician-owned lab need to have in order to support the frequency of testing you're doing and the testing you're doing in general. Alex, if we could put up the slide on the frequency on the risk assessment. No, the other one. I'm sorry. The
LCD. I apologize.
Yeah, the LCD.
Yep.
We'll show you this later. So one of the things that we've noticed in a number of Cellarian's clients, we've seen an increase in TPE audits from small labs with two pain providers up to very, very large national clinical reference labs. But what we've seen is the trend is the same across the board, is that most of the reasons why the labs are getting in trouble or failing their audits is for either lack of documentation of medical necessity, and primarily now we're seeing a lot more with frequency of testing limits, basically violation of frequency of testing limits. And this came from Noridian's LCD, and they're pretty much the same across the board, except I believe for Novitas and but I think all the Palmetto versions are. So basically, if someone is identified as low risk, you can test twice in a year, right? If they're moderate risk, 4 times a year. And if they're high risk, 3 times every 90 days, or on average, once a month. And this is really significant because if the only documentation of risk that you have at all, as clinical reference labs, it's challenging, right? Because you're relying on the physician to try and get this documentation. And most of the time, if there's any documentation, it's usually a risk score. And more likely than not, you're going to see a low risk. And suddenly, the provider who's been sending labs to you once a month for many of their patients, or 4 times a year, you're suddenly losing out on 2 to 10 tests. You're still going to do them because you don't want to lose your client, but now you're guaranteed not to get paid for it, and you're at greater risk from an audit perspective. And so right now there's a huge motivation here to assist both in helping providers document better. And that's going to help the providers document better. That's going to help improve patient care. But it's also on the back end, especially if you're either a POL or a clinical reference lab, it will help an appropriate assigned risk level impacts your reimbursement. And next slide, Alex. One of the other interesting things is that the screening tools are not required. And a lot of people have said, well, I thought we have to have the ORT, or we have to have the SOAP-R. Now, the important thing to remember with these screening tools They're one data point when we talk about patient care. You need to look at your patients in a broader context. And as clinical reference labs, you want to help the providers do that in a simple and easy way. What is important, though, is that they have removed the validated survey requirements, as it's considered to be part of your overall clinical assessment. So what we're talking about today, we are not saying replace your screening tools. The screening tools have a place and it's important, but you need to understand the limitations of them. And you want to, that is one piece of a much broader assessment. So if you could go back to the previous slide. So the key thing here is that, and we talked with one of our clients. We had a conversation with the physician who had written the documentation for the risk assessment in the LCDs, and one of the conversation really centered around what does this mean when we talk about risk. And the key thing that I took away from that was that it's important that if they have nothing else, they're going to go with just your ORT. But the goal has always been that the provider document the rationale for determining what the risk is. And so no, I know. And one of the things that I've also noticed, and Jane and Ellen, I'd like to get your thoughts on this as well, is the increasing number of audits that are occurring. And especially as there's more cuts to Medicare or Medicaid. And the more we see cuts, they have to make it up somewhere. And we are seeing it's not just in the Medicare payers. We're starting to see other non-Medicare payers adopting this policy on risk assessment and stratification. So Jane and Ellen, your thoughts?
I would agree. I mean, certainly from our legal practice, we're seeing an increasing number. And, piece of advice I would give for anyone listening here is to look at the payer policies most applicable to their practice. Look at the Medicare MAC LCDs to the extent that they may exist, because the LCDs, the Medicare program, is not consistent in this area. There are variations around the country. And if you're trying to find a default, so to speak, pick the most conservative of all of those, or maybe I should say restrictive of all of those, from a documentation billing standpoint. But this is where I also want to, from a legal standpoint, I need to separate out what one bills for and what one does, particularly say for a POL, for a medical practice testing its own patients. Because there may be certain services where they can't be billed, or if you bill them with the GY modifier, which is a modifier that basically, it's a Medicare modifier. It says, we know this isn't covered. We're billing it, but we're not expecting you to pay us because we know it's not covered under your LCD or any other policies. But if there is a good medical reason to do the test, keep in mind the risk if you don't perform the test. There may be some things that it is better to go down the path of good medicine and do, even if you're not going to be able to bill for the test. Ellen, your thoughts?
Yeah, I agree with everything both you and Dr. Sprint said. I think that it's critically important to be as proactive as possible. The challenge with that is the reimbursement landscape changes, and it changes frequently. So to your point, Jane, understanding what the payer policy is and going with the most conservative or stringent and doing things on the front end. When I was at a reference laboratory, we would do things to educate our physicians on the front end of the information that they needed, that you walked through at the beginning of this call, and why it's so critical for the patient's benefit to get all that information up front. And so, but these policies change regularly. And so it's really critical to stay on top of them. We used to go by the most stringent policy because typically if some of the policies change and they get closer to being the most conservative one. So if you start there, you don't have to change it as often, but it is important to stay on top of those payer policies.
Great. You're on mute.
Thank you. It's very rare for a payer to become more liberal in what it permits.
Exactly.
As Ellen said, they're usually going to move to the path of becoming more conservative and aligning with whoever's the most conservative in your jurisdiction.
Yep. And so here we are. And now the question is, well, what do we do about it? And that's one of the things that that we came up with was, and Alex, if you could show the opioid risk assessment worksheet. So one of the things that we wanted to do, and it was really important to come up with a solution, because we know for the clinical practice, for the physician providers, changing workflow or asking them to do more work is unlikely, right? And we already found that with medical necessity documentation, which is really the foundation for Cellarian's business, was automating that process, because we know providers don't have that ability. But now when we're talking about opioid risk assessment, there's two really important things that you need. So effective documentation improves patient safety and financial sustainability. So we're talking about patient care, and we're talking about compliance and reimbursement. And so what we developed was a comprehensive opioid risk assessment and stratification worksheet. So I want to be clear about a couple of things. This is not a risk score. It's not a screening tool, okay? And it's not validated. And that's really important to be clear about this up front. What this is a simple and easy, concise way for providers to look and consolidate just in a quick, simple page all the issues that may be going on with their patient related to opioid-related harms, so they can quickly check the boxes here. And so what you'll see here, the beginning is, just talking about risk assessment and stratification, which we already talked about. Here is just a note from the CDC's 2022 clinical practice guidelines when we talk about prescribing opioids for pain. And it talks about the limitation of the opioid stratification tools, those validated screening tools. And again, it's not about you shouldn't use them. It's about you need to understand that they are not great in an overall assessment, and they should not be relied upon as the only tool in order to determine risk in a patient. Now, using it, again, it's a data point that's important. But here's really where the key thing is. And because for providers to go back through their chart and write a big note, they don't have time for that, and they're not going to do it. And so, especially because a lot of practices have just gotten used to filling out the SOAP-R or the screening tool, or the ORT or another screening tool, and that's enough. They do it once a year and that's it. But here, this is something for the provider, and this is something that we are offering to everyone on the webinar. It's not copyrighted. It is, you can edit it, you can take what you like, throw the rest away. It's just a worksheet to help organize in a simple and easy way risk for all the major opioid related harms. So all of these clinical and biopsychosocial issues that are related to increased opioid risk are all here. So the provider just checks the box, and this is filled up by the provider, not the patient. And the provider, and if you'll see here, it's current CNS depressants, sleep apnea, family history of alcohol or substance use, current alcohol use, previous inconsistent drug tests, confirmatory, not screen, depression, anxiety, PTSD, because we know that psychiatric diagnoses increase risk for opioid use, but also other things as medical comorbidities or cognitive dysfunction. All of these things will give the provider an easy but bigger picture about the risk, not just for drug testing, frequency of testing limits, but for how they're caring for their patient. And to look at that, where that patient may be higher risk, but it's appropriate in that patient for that situation, where the benefits outweigh those risks, even though they may be a higher risk patient. But what this does is, in one easy place, they can look at the issues and then just click high risk, moderate risk, or low risk. So what does this translate for the labs? So for the physician-owned labs, what you already have this documentation, download it and use it, you put it in the patient's chart and you're good to go. And you now have a clear documentation, not only just of risk, but why. And again, what's the rationale behind my risk stratification? Now, there is no clear standard on what defines low risk, moderate risk, or high risk when we're making clinical decisions like this. It is you as a clinician who makes those decisions. And so what I may consider high risk, another may consider moderate risk. But the important thing is that you have it documented. Okay. And so for the clinical reference labs, you can use this as a tool for provider education. So you go to your physician clients and you offer this as, hey, look, here is just a simple, easy worksheet that can help improve patient safety. And that's important for them. And the next question is, well, okay, how often should I do this? Well, the reality is that in an ideal world, you would reevaluate your patient's risk level and assessment at every visit. In a practical sense, from a clinical workflow, it's unlikely that most providers are going to do that. So what we suggest is, at a minimum, you do it at the same time that a patient does their screening risks tool. And again, we even have included opioid screening risk tools here as well. So if even as little as once a year, but you want something documented here on those patients. So it's a great opportunity to, one, promote patient safety, provider education, compliance and documentation on the front end. And the result on the back end is better patient care and a more appropriate reimbursement and frequency of testing limits based off of risk, with the documentation to support that. So that's going to help you as a clinical lab, both in terms of your risk, your audit risk on the back end, but also your reimbursement for frequency of testing. And for the physician-owned labs, it's the same deal. So I want to pause for a second for Jane and Ellen and see what your thoughts are.
I think this is a great tool from an audit standpoint. Any and all documentation is good to have. And also, the more individualized the documentation, the more individualized the assessment of the patient. One of the things I didn't mention before, but certainly a perceived factor, I would say a factor that I perceive in payer audits with respect to success or non-success, is when payers see that the exact cookie cutter decision has been made and is applicable to all patients, the payers tend to doubt medical necessity. But the more factors that a provider is taking into account to assess the patient, and this type of worksheet, for example, it is a tool. It is but one tool, as Dr. Sprint said. I mean, there obviously you need to take into holistically account the entire patient situation. But this is good. It is adding more information. The other thing too, I'll throw in, because I know there were some questions in the side chat here, because I think this also ties in a bit with a worksheet, because someone was saying, well, for an independent lab, it's hard because an independent lab isn't seeing the patient. What can an independent lab do? An independent lab can, as Ellen had mentioned before, trying education of clinicians, to the extent that worksheets can be provided as voluntary tools that clients can use. This kind of worksheet would certainly be of benefit. Another is, in addition to a worksheet such as this, the physician would be utilizing and providing it back, would be on the requisition, be it electronic or paper, because I recognize people have both. For some of the major medical necessity issues or major issues that payers or an LCD may have, having some check boxes that the provider can check, yes, applicable, or no. Now, the physician may not fill them out. You can't set something up that requires someone to fill out something that will get you paid. I mean, that's not appropriate. But you may have physicians who still, if it's easy for them while they are ordering to check a box of something that is applicable, it gives some documentation to hang your hat on later.
Mhm.
Ellen,
Yeah,
I have your thoughts because you're much more on the provider education side.
Yeah, I'll add to that. We had a lot of success with that, whether it was in toxicology and opioid or other lines of business, that as we look at the payer policy and would see, going back to our most conservative payers, what are they requiring? Then designing our requisition with some of those check boxes along those requirements. So your other payers are not going to be upset if they get more information, right? It's going to be, but you're covering yourself for that more conservative one, or if the policies were to change and you didn't catch it. That way you're not having to recreate that rec over and over. You might still see denials, but you're more likely, if you're following the payer policy, to win on appeal. And so, it could be from over testing denials, if you will, if you're documenting what Dr. Sprintz is talking about, or just a general denial. If you're following the payer policy, you're more likely to win on appeal if you've got that information up front. So there's a couple different ways to do it through the worksheets like this. These were very helpful, to bring in and help in terms of the education. Not every regional lab has salespeople who are out there, so there's other ways to market it and get it out there. Certainly your sales organization, if you have it, should be educated. But it is a challenge because you are, as a reference laboratory, and I think Dr. Sprint said this up front in the presentation, you're not in touch always with the physician and so you don't have as much control over the filling out of the information for the patient up front.
Yeah, thank you, Ellen. And that's really key, especially for the clinical reference labs, in the sense that right now, and again, if you have nothing, if you're a clinical reference lab and you've got no documentation of any risk, you're at best going to get the low risk frequency of testing limits applied. If your clients are all, just using a screening tool that results in the predominance of low risk, you're stuck with that. So this is, how much of an improvement all depends on the patient population and their risk as determined by the clinical providers. But right now, you're stuck with nothing of just the screening tools. And this is a significant opportunity for improvement, both in patient care and provider education, but also documentation to support the appropriate level of risk that is really more accurate than just a screening tool. And someone in the audience had a great question. They said, well, if this is not validated, how is that going to be perceived in an audit? And what I want to be clear about is that, one, the sheet itself in that worksheet does have a little section for the ORT or the SOAP-R or whatever screening tool du jour that the providers use. I'm not saying don't use those. Those are a part of an overall comprehensive assessment. But to be clear, a risk assessment is a clinical decision. It's not a validated issue, okay? Because again, what the payers are saying, they actually removed the validated screening tools as a requirement, okay? It's important that a clinician evaluate a patient and look at all the factors that go into it and make a clinical decision about the level of risk. That's an individual provider's determination. There's not just a chart with a score that says what it is. And so from the perspective of a CMS audit, what you have here is this is a documentation of the rationale for the risk level that is determined. And that's really key. It doesn't have to be validated. It has to be documented. And again, if you're ordering drug tests, your providers are ordering drug tests, or if you're a POL, you also want to have medical necessity documentation. That's a whole separate category that helps to support this. But when we're just talking about frequency of testing as it relates to opioid risk assessment levels, again, they talk about assessment levels and plans, not validated screening tool scoring. And that's a very key difference that I think a lot of people miss when they read the LCDs, because the LCDs are a little bit misleading in that regard. But if you read closely, it's very clear that they care about your overall assessment of the risk for that patient.
We can go ahead and hop into Q&A if now would be a good time for it, Michael.
Sure.
All right, let me get our information slide back up there at the end in case anybody doesn't have a chance to get something addressed here. But a few of these we did touch on live, but it might be good to reiterate some of these that have received a few upvotes. Can you speak at all to the type of reception labs have received when asking ordering providers to complete one of these for each patient? Is that the expectation? And then is a provider signature required, or could it be filled out by anyone in the office?
So to answer the first question, the biggest question is, wait a minute, how often do I have to do this? Right? Because again, and everyone is worried, like, look, if I've got to ask my doc to do this at every single patient visit, it's never going to happen. And I get that. So what we've often said is, in an ideal situation, you would fill it out like that. But, at the very least, do it at the same time you have your patient fill out their risk screening tool. So when you screen them, you do it, you fill this out. And the only other time I would say fill it out is if something changes with the patient. Are there new risks? Have some risks gone away? And then in that situation, so the provider needs to understand that it's not going to be overly burdensome. It's just a simple, fast way that they can do it at a minimum once a year. In an ideal world, it would be better to do it more frequently. But really, even at that level, that's more documentation than they've had in their chart to date. So that would be really the first question is at a minimum, do it like that. On the, could you repeat the second part of that question?
Yeah, it doesn't require a provider signature. So could it be filled out by anyone in the lab?
Although it doesn't, and again, it's a worksheet to assist them. My suggestion, it should be the provider who's ordering the test who determines the risk level. What someone does in clinical practice, I don't know, but it's, we've had one of our clients who actually modified this and included a signature at the bottom. So again, this document is, not copyrighted. We want to give this away because we want to improve patient safety. We want to improve, provider documentation, and we want to help people stay compliant for reimbursement. And this can be modified however they want. So you can add a signature, provider signature to it. You could have someone else go through the medical chart and check all the boxes to do that. And, we actually are working with another company that Cellarian's working with Shadowbox in a way to automate some of the filling out of those, which can be helpful. Or I'm sorry, with not Shadow, I apologize, with ShoreMed in order to do this. And what that does is actually help with just making it faster. But they could have an MA or a nurse practitioner or someone else do it, but the physician should be the one who makes the determination of risk.
I think a lot of this I would view as analogous to, if we go to our physician office, my physician is not going through my, history with me, but the nurse may be, or a physician assistant, but it does become part of my medical record. And usually the physician is signing off on that somewhere in the medical chart, particularly to support the billing for the office visit. And it would be ideal from my legal payer defense standpoint to somewhere, if the physician or the ordering provider is not signing this document, if someone else is completing it, that still becomes part of the intake or that patient visit, where there is a signature captured for all the documentation that's created during that patient visit.
Mm-hmm.
Thanks for those answers, Michael and Jane. We might be getting a bit broader here, but we do have a few different questions that touch on this issue with payers pushing back on medical necessity. In this specific example, the questioner is an independent lab struggling with payers such as Humana and Superior for confirmation drug testing with 7 to 14 classes or more considered not medically necessary. The issue that they're running into is providers are pushing back, saying smaller panels won't give them the information they need. So what would you recommend for the lab in this situation?
So there's a clinical answer, and then there's a reimbursement and compliance answer. So from the clinical answer is, as a clinician, you should order the tests that you feel are necessary to enable you to do what's best for your patient, right? And generally speaking, and again, I did chronic pain and addiction. And so I had very high risk patients, and I often would have very broad testing panels because, especially with addiction, it's not predictable. They're not going to do just you. And given the level of tainted drugs in the drug supply, especially for people that are buying stuff off the street, you don't know what you're getting or taking. So those tend to be broader based in that regard. Now, from the payer side, they've made determinations, and it's a policy decision that that they won't pay for greater than a GO 480 or greater than 14 tests. So there's a couple ways to do that, and I'm going to let Jane handle that first question, because she and I have had this conversation multiple times.
And it is difficult. And it depends exactly where the payer is coming from in terms of how strict their rules are. It may be a situation where there is a presumption of a lack of medical necessity for a greater number of drugs that can be overcome with medical necessity documentation in the chart. So you do want to drill down to make sure that there may be an avenue with appropriate documentation. For example, in Dr. Sprince's example, a brand new addiction patient coming in where you don't have any testing and you really have no idea what's going on. A broad panel makes sense, but it'd be important to document that patient history to explain why the broad panel is needed. But it might not be needed for the next time, or maybe not the next, but it might not be needed, maybe it would be. Or if, for your original example of the 83-year-old patient who, is on gabapentin and one other drug, and you're not going to be as worried about what she's taking. So in that case, the payer would have a lot more justification for saying that the broad panel. However, having said that, throughout the laboratory industry, there are many examples of situations where a panel is run that may have more analytes or probes or other components than the laboratory actually submits a claim for. Is that a perfect situation? No, it's not. Does that happen? Yes, it happens fairly frequently because the lab knows it's only going to get paid for a certain number. Payers, could they make an argument that that's a false claim and that you have billed for something that differs from what you actually performed? Well, they could, but as a practical matter, I have not seen private payers or even government payers come after someone for that, what I'll call down coding. Where the risk is you don't want to say to your clients, come to us, come to our laboratory, because we will do a broad panel on everyone, but we're only going to bill for the narrow panel. So your patient's only going to have a very small copay. If you are advertising that you are going to run a broad panel and basically all those extra tests are free, so to speak, that's where the problem comes, because it looks like you're inducing someone to obtain testing from you. Whereas if behind the scenes you decide to bill with a code that has fewer numbers of tests, I think the risk is manageable. I mean, Ellen, your point of view, because obviously this is something that sales would run into all the time. Mm-hmm.
Yes, and you would remind me all the time about not broadcasting and promoting in a certain way, which is a critical piece of information. So, I think we mitigated the risk two ways. One is we didn't do a lot of custom panels, or we tried not to. There were certain necessities to do them when we had to, but we did try to stay within the number of classes that the payers would pay. And then the second thing is documentation. So the more information you have to make your claim. So as Jane was talking about, you might need 14 classes because of somebody's patient history. The more information that you have, the better you, maybe not on denial, but on appeal, certainly. and thinking about that individual patient, what is necessary for that individual patient and what testing do you need to order on that individual patient. So I like the two examples that were given because they're very different patient types. An 83-year-old who's been treated, who's on a couple different things versus somebody with who's a new patient in the unknowns. But the more documentation you have, the more likely you are for success. But the custom panel thing was also, we tried to limit that as well. So we could help our physicians understand their risk too, in terms of reimbursement.
Yeah, and I think to piggyback on that, there's a difference between frequency of testing, meaning how frequently am I running tests for this patient, versus how broad or narrow the number of tests that I'm running on that patient.
Mm-hmm.
And that's different. Sometimes I think people mistake the risk score with panel size versus frequency of testing. But the other key thing here too is the difference between analytes and drug classes. And that's one of the things I've had a conversation with a number of our lab clients, is that how a lab determines their drug classes impacts that. So they could have a panel that may have 20 analytes, but only 14 drug classes, depending on how they do that. And that's important to remember also. And so it's, unfortunately, and Jane and I have talked about this before as well, is that there's a lot of things that are unfortunately in the gray because they're not clearly defined for us. What I do like is a lot of the federal, payers, they have more clear guidelines. And so these are things where you do the best that you can with the information that you have available. Because again, trying to get your providers to tell your providers to test less, and the provider's like, that's not safe. That's a tough situation. So it's really about kind of looking at how you classify those. And there are times where it may be where, hey, look, I don't say anything to the provider that I'm not going to bill for their entire panel, because they have, and again, if you have medical necessity documentation to support what they're testing for, you're in supremely better situation than a doctor who orders a larger panel, or even a panel within those ranges, but has nothing to support it. So really trying to get that documentation, that's really, the foundation of Cellarian, of what we've done, is trying to help with getting the documentation when you know that the providers aren't going to have the detail that you need.
Another thing just to keep in mind, and this is really, it applies to the situation we're discussing now, but it's also a broader statement. If you are audited and let's say there are 30 claims, 30 patients that a payer has provided for you to provide documentation on, I mentioned before the 4 items that you really need to get, which are the medical record or medical documentation, supporting why the testing was ordered, the signed test requisition, and if it's not signed, get an attestation from the provider who is then signing saying, yes, indeed, I did order this test. The test result, and then some medical record documentation or something drawn from the medical record that's going to support that the testing was utilized, considered by the ordering provider. But with many of these, and particularly the situation we're just discussing, where you may have tested more than you billed for, it may not be apparent when someone's looking and trying to sort this together. Remember, this is going to a payer, to someone who is incentivized not to spend time to find out you did things right. Their incentives are just the opposite. Get through it quickly and find out that, or make a determination that something's missing or it's questionable, because you really have the burden of proving what you did was correct. In those situations, it can be very useful to put a cover sheet narrative. Don't make up things, but draw things from the documentations you have. And certainly this is something, I know Cellarian has a product which is wonderful to do this. So whether you use a product like the one Cellarian has, or you're doing it manually, putting that narrative, hitting all those points, connecting the dots. Don't just assume whoever's reviewing your paperwork will connect the dots. You may have to put it in an explanation for them to make life easy. And that can be very, very helpful.
Yep.
Well, I think with that, we're going to go ahead and wrap up here and give everyone just a few minutes back on their lunch hour. I want to say thank you again to Dr. Sprintz, Jane, and Ellen for joining us today. Very informative. If you didn't have a chance to have any questions answered, though, feel free to follow up with us at the email address you see on your screen. We'd be happy to forward any questions as well to Dr. Sprintz or Jane if you have any legal or documentation considerations. But otherwise, we look forward to seeing you all next time.